Good morning. I am delighted to have you all here for our next iteration of the Pennsylvania Coalition for Oral Health's Workforce Webinar Series, Understanding the Role of Public Health Dental Hygiene Practitioners. My name is Helen Hockey. I am the Executive Director for PCOH and happy to serve as your host today. This webinar will be recorded and shared with registrants, and there should be some time after the presentations and discussion for some Q&A. So if you have any questions as we kind of go through all of the slides, please definitely feel free to type them into the Q&A portion. There should be a little bar at the bottom of your screen. Okay, so without further ado, we'll go ahead and get started. Our agenda today is really just a continuation of how we've been exploring all of the factors that affect workforce and oral health workforce in Pennsylvania. We will be joined in a bit by Siebka and Reilly, who are going to share their perspectives and experiences working as public health dental hygiene practitioners. But before we hear from our presenters, I do want to give just a quick overview of our Pennsylvania situation and a little bit about PHDHPs. So, some of you are going to be at different levels of familiarity with PHDHPs. I know we have quite a few on the call. I know we have even students, dental hygiene students, who might one day become certified as PHDHPs. So we wanted to give you guys a little bit more information about what that situation looks like in Pennsylvania. And as always, we do like to share a link to our state oral health plan to start. We have a 10-year plan that was developed by the Pennsylvania Department of Health to really guide our state to better oral health. So our oral health workforce is one of those three main priorities identified in the plan, and PCOH is actually contracted to help implement and track the strategies that are being used to improve workforce in our state. So we have a little bit of a role in sort of making sure that these things move forward, and that's one of the reasons that we do the webinar series. And if you haven't had a chance to review the state oral health plan, I would highly recommend you do so, since that's really the thing that guides a lot of the policies, the funding, sort of everything that happens around oral health in the state. And then as part of these webinars, we also like to share the situation of where our dental provider shortages are across the state. So we've got some pretty vast amounts of Pennsylvania that are designated as dental health professional shortage areas, particularly in the northern tiers, central tier. We've kind of got entire counties that are designated as shortage areas. And within those shortage areas, we actually have more than 2.2 million Pennsylvanians living. And those are folks that are definitely lacking access to dental care. So there's a lot of statistics there to share. Basically, I always like to just sum it up and say that we need a lot of dental providers. And we need more than we're putting out that are actually returning or coming to practice in Pennsylvania. So that's one of the reasons we look at other options, other provider types, other methods of practice. Any way that we can get more care to more people, that's going to be really, really important. So those are the efforts that we need to address some of the gaps in Pennsylvania and make sure that we're increasing dental care. So leading into that, in this slide, we really wanted to kind of say, well, why do we need public health dental hygiene practitioners? Wanted to sort of examine on the left what would be considered a traditional dental care model, the barriers that people can face when trying to work through that model in accessing dental care, and then talk a little bit about a public health practice model. So, we have a lot of people in Pennsylvania who are seeking to establish a dental home. They want to find a dental practice. They want to find a dentist who can see them for all of their needs. But a lot of times, by some of the barriers you can see here, there are reasons that they can't access that care. So, we know limited providers is a major issue. We've talked about that on some of the previous webinars. Transportation can be an issue both in rural and urban areas. Cost and insurance continues to be a #1 reason that people don't seek dental care. We have many people in Pennsylvania who don't have dental insurance or access to dental insurance, or they can't afford care that isn't covered by their current insurance. Time off of work and time off of school becomes a major issue as well. There are limited numbers of dental offices that offer evening and weekend hours, so that can be a major barrier, and appointment availability, which ties right into that. So just talking with folks around the state, we are hearing a lot of offices now pushing people out 6 months, 8 months, 10 months, 12 months for appointments, and so that can make it extremely difficult for people to get dental care when they're actively seeking it. So if we compare that to a public health practice model, really when we talk about public health practice models, we're really talking about bringing care to the community, right? So rather than teaching or trying to provide care for one individual, we're talking about providing care to an entire community. Now, it's kind of interesting because it meets people where they are. It's not something that we've traditionally done in dentistry. So we look at things like mobile programs, federally qualified health centers, and, all of the different sites that they work, things like WIC offices, early childhood learning programs, community health centers, schools, medical offices, long-term care facilities. There's a lot of different places where, for the purposes of today, public health dental hygiene practitioners can practice, but you wouldn't maybe always necessarily find a dentist practicing in that location. So the goal of using PHDHP is to integrate dental care into those accessible settings. That way we get to offer more care, more education, and more referrals, right? So those nice warm handoffs where you have a provider telling you you have needs, and this is how I can help you get those taken care of. So the referrals are really, really important as well, because that's what's going to effectively get a patient connected to a dental home. So that model not only addresses some of the barriers of a traditional approach, but also enhances the overall community health. So the introduction of public health dental hygiene practitioners, or PHDHPs, has really been a transformative step in expanding the dental workforce in Pennsylvania. So back in 2007 is sort of when, bill was introduced, passed, we had an actual law that created PHDHPs as a position. And that allowed dental hygienists to provide services in designated public health settings without needing supervision. So a pretty pivotal moment for public health in Pennsylvania, I would say. It took a few years for the State Board of Dentistry to outline all of the regulations and the specifications of what that position could look like. And then fast forward to today, about 11% of our current dental hygienists are certified as PHDHPs. Now, of those, only about 1/3 of the ones certified as PHDHPs are actively working in that role. So that's something we're going to explore a little bit more. PHDHPs play a really crucial role in expanding access to care. So they get to provide preventive dental care, education, conduct screenings, and they can implement some disease prevention strategies directly with patients. More importantly, they really do serve as a bridge. So they connect patients to dental homes by identifying needs, making referrals, and coordinating follow-up care. So the goal of all of this is that we're maximizing the capabilities of the entire dental team. So PHDHPs can help extend the reach of current providers and also extend the impact. So making sure that more people directly in the community get the care that they need. So as we move forward, we're going to go through just a couple slides talking about the latest results from our 2026 PHDHP survey. So PCOH was able to send out a postcard survey with QR code to all of the PHDHPs certified in the state. And we got a decent return, we'll say. The survey was shared with 1,100 PHDHPs across the state. It got about 142 responses, so that's about a 13% response rate. For a postcard survey, that's not too bad, though we always like to say that any of the data that we are presenting today need to be interpreted with that in mind. Obviously, 13% return rate, response rate does not reflect the full field of public health dental hygiene practitioners out there. So first off, asking them all how many are working in public health settings, we got a return of about 41%, primarily working in public health settings. Almost 60% do include children in their practice, which I think really highlights the role of PHDHPs in early preventive care and education, which is kind of how we foster those lifelong oral health habits. Next, the ability to bill Medicaid for their services. Public health dental hygiene practitioners were granted the ability to be credentialed with managed care organizations in the state in 2017. And so since then, we've seen an uptick in those numbers. So about 21% of our respondents are currently billing Medicaid for their services. So that's really great because that means it's an additional provider in the healthcare payment system, which should be benefiting underserved populations. And then additionally, just talking about representation for the survey, all but 3 counties were represented in responses, which I think is really good and gives us an idea of the fact that there are PHDHPs in all areas of Pennsylvania. So as we continue, we're going to talk a little bit more about certification utilization and public health settings. So as mentioned on the previous slide, about 40% of our PHDHPs are primarily working in public health settings, but there's some disparities here. We've got a lot of folks that are certified, but maybe not using their certification in public health. So 40% also do either not work in public health settings or don't utilize their certification. So that highlights an area where we really do need to increase engagement and utilization of PHDHPs in those public health roles. So when we look at where they're actually working, a majority of them are working in federally qualified health centers, which, if you're not familiar, are amazing health centers all around the state. We have more than 100 dental sites around the state that are federally funded and do not turn patients away due to lack of payment or insurance. So really great places to see PHDHPs working. We do see that schools and school-based programs account for about a quarter of where they're working, which makes a lot of sense. I think that's probably not a surprise to anyone. And then we see some smaller numbers at rural health clinics and at managed care organizations working with insurance companies. And so, we'll hear a little bit more about that today as well. So we want to use this information to sort of guide our future strategies, right? So we've got to know where everybody's working and what they're interested in and what they're doing before we can really try to devise the ways to maximize the impact of our public health dental hygiene practitioners. So the last slide of data I wanted to share to just talk a little bit more about the populations that were reported being seen by PHDHPs and their billing practices. So we mentioned that nearly 60% see kids as part of their services. What I love to see is that of all of the ones who specifically said, yes, I see children in my practice, 62% of them see kids at age 1, which is a really high number and very encouraging because that tells us that we've got a great proactive approach to these kids getting seen. And then at slightly lower percentages, I would say half of the PHDHPs reporting, we're seeing individuals enrolled in Medicaid, we're seeing individuals with disabilities, and then the uninsured, right? Because that's a whole other issue with so many people not having dental insurance. So when it comes to billing, there were a few noteworthy statistics. So we mentioned 21% are billing Medicaid, but only less than 1% are billing both Medicaid and CHIP, which really is kind of interesting because those programs, even though they're not the same thing, they are a little bit tied at the state level. So we think that may be due to a lack of knowledge that CHIP programs recognize PHDHPs as billing providers. And then we have 6.5% not billing Medicaid or CHIP, which to me tells me we have a place for growth and support there as well. We've also heard anecdotally directly from PHDHPs that sometimes they're just not sure how to bill insurance. It's not something that, they're taught in any type of programming. So that can account for, 89% who are not billing insurances at all. So if you're interested in seeing the full results of this survey, because we just wanted to touch on a couple things, the link to our one-pager will be shared on the slides that you receive after today's presentation, and we'll get that shared out with everybody so you can kind of see the full gamut of information that's out there if you're interested. So now on to the good part. I'm going to turn the mic over to our presenters for today. We invited 2 practicing PHDHPs to speak with you all and share a little bit about themselves and the work that they do. So I'm really happy to be joined by Crystal and Leslie, both of whom are great partners of PCOH. They do wonderful work in PA. And we're going to hear individually from both of them just for a few minutes to learn a little bit about their work and then bring them back for a panel discussion to ask some questions. So I do want to start with Crystal, and I know we were having some tech trouble with her camera, so but she is here and ready to join us. And Crystal, if you can just share a little bit about the day-to-day work that you do as a PHDHP, that would be great.
Okay, hi everyone. Thanks for being here. Yeah, my name is Crystal Siebka, and I am a public dental health hygienist. I currently fulfill a full-time position with UPMC Health Plan. My position with UPMC is kind of more of an administrative role, in that we do a lot of member engagement and community engagements. Our goals, we focus on education, and like Helen had said, bridging that need for care. We're able to assist our members with accessing care. They don't always know where to go to get dental care or who accepts their dental care. So we're able to connect with them and support them in that way. For me personally, the counties that I cover for UPMC is very rural and lacks access to care, like Helen had said. All of my counties were dark blue. I have 2 of my 6 counties that have no MA providers in the entire county. The one county doesn't have a dentist in the entire county, so nobody has dental care. But with that, we are able to collaborate with, mobile dental providers and organize and bring mobile events to those areas to provide preventative care for those folks. I've gotten very good at event planning. We do these from start to finish. We're able to, through our partnerships with our community partners, health and human service agencies, we build relationships with those folks and they recognize that need. So we're able to, secure proper venue sites. Our public dental health hygienists have to practice in specific treatment sites. And so we're able to secure those venues, get the word out, help fill a schedule for that mobile provider to bring them in and provide that preventative care. Provider support. Our Medicaid providers are under a tremendous amount of stress and pressure. So knowing that they can pick up the phone and call that dental care manager assigned to their area, with some questions or just where can I go to get these answers is huge. I very much enjoy engaging with our dental providers and letting them know that I'm here to support them and help them. Our focus is primarily, like I said, dental education. Our team, we just do so much dental education all over Western Pennsylvania, and Jasmine is located in the Lehigh Cap area, so she's out further east. But we work with Head Starts, pre-Ks, and we don't educate just students, we educate the staff. We work with CYS and help foster families find care and educate foster families. I go in and do dental education for the independent living kiddos that, they need all kinds of support because they're taking care of themselves and they don't always know how to do that. So I collaborate, support, and educate, and that's my day-to-day.
Well, that's pretty amazing, definitely. And having worked with a lot of the UPMC PHDHPs, I know you guys are doing some really great work. So we're going to come back to you. I'm going to give Leslie a few minutes to talk through some of the work that she's working on, and she's kind of on the other end of the spectrum, at least geographically, in the state. So I will. So welcome, Leslie. I've got your slides pulled up here, and if you want me to progress, just let me know.
Sure. So hi, everyone. Thank you, PCOH, for having me on the panel today. I really had an unconventional path to public health, and am excited to just share, what got me here, my initial foundation in public health, and then, where I'm at, what I'm doing, and how I'm balancing both sides of the fence, in terms of clinically and administratively. I graduated hygiene school in 2010, so shortly after we had a lot of legislative changes, including the introduction of the PHDHP, the introduction of local anesthesia. So there were a lot of scope changes, I feel, just for hygienists in Pennsylvania at that time. I mean, if my story can help others, absolutely, I want to share it. I was completely blindsided by a divorce shortly after graduating hygiene school. So I needed to find work that was stable, provided benefits for myself, my child, and that's really how I found my path in public health. I took a job working in the Philadelphia County prison system, mostly as a surgical assistant who could also do hygiene. I spent about 2 years working there. That's where I obtained my PHDHP certificate. And I really fell in love with treating a different subset of the population here in Philadelphia. Clinically, the best experience I have ever had. I miss it every day. I never thought I would say I miss jail. But that is, I encourage every hygienist, every student that's practicing in dentistry to really seek out those clinically diverse avenues of dentistry to really gain a sense of perception into what school does not teach you. After working in the county prisons for about 2 years, a position opened up in the county health department, where we have 8 federally qualified health centers throughout the city limits of Philadelphia, to which the presentation, like that information from the survey, showed that Philadelphia, as much of a major city as it is, it still is deemed a provider shortage area. So that's definitely something that I feel is reflective of what I'm witnessing as a provider and administrator here in the county. My job currently, it took me to full-time work 5 days a week in brick and mortar federally qualified health centers here in the city. And I truly feel that is what launched me into my love for public health and really understanding, who we're serving and the determinants of health, and really looking at providing oral health care in a different aspect. Next slide. So these are just some photos, one of which on the left side, that's like, yeah, me when I'm clinically facing. I worked with the director of my health center to obtain a literacy grant where we were able to put a small reading station in front of the dental waiting area for children and their families, to just kind of hang out, read books, just distract them before they do come in and receive services, whether it's with dental or medical. And then an expansion grant that allowed us, as you can see on the right photo, that allowed us to expand one of our larger, most in-demand health centers that's located in South Philadelphia. Again, just to provide more access to the population in that catchment area. Next slide. So as I said, these are the 8 health centers, all located throughout the city of Philadelphia. I'm currently completing my clinical work at just one, but in my almost 10 years of working for ambulatory health services, I've rotated through almost all of them, with different patient populations, cultural backgrounds, language barriers, health literacy statuses. So it's really provided a vast array of patients, and how to render care towards the population and residents of Philadelphia. Next slide. Our mission statement with ambulatory health services, it's to provide healthcare to Philadelphia's poor and medically underserved residents. And in doing so, we're providing quality and dignified services that meet their personal healthcare needs and result in improved health status. Our health model is to be recognized as a primary healthcare network that contributes to an improved health status for Philadelphia's residents. Next slide. A little bit about what we do, who we are, just in case anyone is looking to, seek employment in something similar or with us. We are a primary healthcare service model. We've been working with our residents since 1969. Again, insured, underinsured, as long as you are a resident and can provide proof of residency within the county, you're eligible to receive services regardless of your income status. All 8 of our health centers do maintain patient-centered medical home status, as well as with a behavioral health distinction. We are also an NHSC, the National Health Service Corps loan repayment site, that has been able to afford us the opportunity to obtain not only dentist, hygienist, and also in collaboration with our medical providers as well, to again serve in these health provider shortage areas. Next slide. A daily workflow for me, what it looks like right now when I am patient, it's a minimum of 8 patients a day. Sometimes the schedule does allow for me to see new patients or complete health screenings on new patients seeking oral care. I'm pretty much running the show in terms of setting up, breaking down, turning over my operatory, taking my own radiographs, processing my instruments, completing my charts. It is long. It is a long process, but I feel at this point, hygiene school prepared me for anything. If I am working without supervision, I do have to communicate to an offsite supervising dentist to address any emergency or patients that are coming to me in pain by way of a virtual encounter. That's definitely cumbersome, and I think I'm looking forward to hopefully speaking about that a little bit more at the end of the presentation in terms of just that autonomy and the limited scope that we do have with the way we can serve patients as a PHDHP. We're able to interact with our patients in this health center, but for me, most of my patients do not speak English as a first language. So in addition to your treatment plan and completing your services every 40 minutes, you're now having to do that in a language that may not be my first language. I have to stop, get an interpreter, page for an interpreter, call the interpreting service that we have. So that is also something that I've had to learn with time, making sure I can educate my patients with oral health care resources in a culturally appropriate way, at their health literacy level, making sure it has good readability, it's not too overwhelming for them, something that we might be able to understand more so at our level with having extensive dental background is not going to reach someone who never finished grade school. Sometimes we do have patients who cannot complete their health history form just because they simply can't read. So it's a matter of just meeting people where they need to be met in order for them to receive access to oral care. Next slide. My administrative role, what I do the majority of my other time during the week, working with grant specialists to maintain funding, through different aspects with staffing, program goals, equipment. I'm also leading with the clinical supervisors who are also 2 dentists to make sure our program meets CDC and state requirements with terms of infection control, scope of practice, establishing engineering controls to keep staff safe, especially when it comes to instrument processing, sharps maintenance, our amalgam disposal, just to name a few. Working with purchasing teams within our department to ensure we have the proper tools and equipment to be able to continue to provide services in our brick and mortars. And then interdisciplinary care with different teams within the health center, with medical, with family planning, with podiatry, and also taking into account the requests of the board of directors. Next slide. In terms of expanding access to care as a PHDHP, I feel the autonomy is a great benefit to have. It's important to be sure to to confirm that we are, or myself, that I am practicing within the indicated specs of a PHDHP in this setting. I think that's something I'm always reaching out to Helen and her team about, to clarify certain things. And every day you're learning something new. There's definitely setbacks when a dentist is not available and I am the only provider on site, and to still be limited with things I can do, especially in terms of subgingival treatments or tasks that may fall under direct versus that general supervision. It's important to be sure of what you're doing in that PHDHP role. Next slide. And that's it. That was it. That was it. So there's my information if anyone wants to reach out or had questions or just looking for, in terms of shadowing what we do. That's my information. Thank you.
Mm-hmm. Thank you. So now we're going to go through, I know we're starting to get some questions in the Q&A, and very much appreciate you both sharing a little bit more about what you do. I will say, just a couple things that have come up over, preparing for this webinar and questions that we hear from folks a lot of times. Crystal, you're primarily working in a rural setting. Leslie, you're primarily working in an urban setting. Are there things that you notice that are really just affecting you because of the setting you're practicing in, whether it's rural versus urban? Anything that seems primarily focused for that specific area?
I feel provider retention in terms of, and I know we've talked about this before in some previous presentations, Helen, with dental students once they graduate. It seems like the state, I guess, as a whole is not necessarily retaining all of those new grads in terms of dentists. Philadelphia has two of the three major dental schools, if the only dental schools, I believe, in Pennsylvania right now. And at least for us, we struggle to find full-time dentists, part-time dentists. And I don't know if it's because public health settings may not be able to offer full scope services that they've just perfected in their dental school training. But I think for me, that's one glaring deficit that we're facing, I feel, just in terms of provider retention.
Makes sense. And how about you, Crystal? How's rural treating you?
I agree with Leslie. Finding dentists is absolutely uphill. We've had several of our dentists, private offices, like retire and try and sell their practices. They were, dentists would come to the area. They love it. They think it's beautiful. They're excited about, going to the Clarion River fishing. But then the family shows up. The wife is not happy. There's no shopping here, and they are concerned about the ability of the school districts, and they don't want to live here. They don't want to settle here. I think one of the biggest hurdles we have here in the rural area, though, is transportation. We don't have busing that goes out to the areas that we serve. Transportation is definitely a huge one for here. Some of these folks live on back roads that have no winter maintenance. So even weather can be a hindrance here for us with snow and whatnot. But transportation, I think, is our number one, and lack of providers. We just don't have providers, like none at all, like zilch. So that's a huge issue. And they can't afford to drive 2 hours to get to, someplace like Butler or Pittsburgh, or that. They just don't have the ability to get there.
Yeah. We've seen that with our specialists for sure too. We've seen that a lot. We had, a previous webinar on dealing with specialists, and those numbers are very bad as well. So travel is a huge deal. I'm going to jump a little bit here because there's some questions coming in, and some of them are kind of related to things we're talking about right now. So specifically, Leslie, I'm going to ask you a little bit about if you can speak a little more to loan repayment for students, like just to kind of explain a little bit how that works, because I know we have some students on the call today. So what that repayment site looks like.
Absolutely. So that is a program through NHSC. I would encourage you, if you haven't explored their website, definitely explore it. It reaches, I believe, when I last was completing my term with the NHSC program. It was only applicable to dental students, dentists, and dental hygienists. I don't believe they expanded the job positions for EFTA or dental assistants, at least here in Pennsylvania. So I would check that. I applied 3 times. And on the 3rd time, I finally was accepted. It was a huge financial relief for me. I already was working in a shortage center or I guess workforce area that qualified and met the needs. They definitely do require you to report, your hours worked, any time taken off. I think it pretty much aligns to your regular full-time duties in terms of your work hours. I didn't feel there was any difference for that. But it is a continuation program. Initially, I believe it's either a term for 2 or 3 years, again, depending on dentist or dental hygienist. You do have to attest every 6 months. Your program leader, the liaison that's generally at your employer that connects with NHSC, does review and submit your your service verification every 6 months to just attest that you've completed and held up your end of the agreement in terms of serving the community. But it is definitely a program. If I could help anyone or answer any questions, my email, I'd be more than happy to speak about it. But it has helped retain providers within the public health setting, medically and in the dental fields as well.
That's great. Thank you. And I think it's probably been close to a year now. One of our workforce webinars was focused on loan repayment models and programs. So that is available on our YouTube channel. If folks are looking for, a quick little blurb about more information there. So that's really great. I do want to, kind of bring back a little bit. I know that you guys have been doing this, both of you, for a long time, and you've seen a lot of patients. You've had a lot of situations come up. Is there any specific success story or challenge you were able to overcome, just that, as a PHDHP was something that, maybe a traditional hygienist might not have been able to do? Anything that comes to mind? Crystal, I saw you come off mute, so you're ready.
Yes. 3 years ago, I think it was, one of the maternity nurses approached me and said that, she could not get care for her pregnant moms. Medicaid covers 3 cleanings for pregnant moms during pregnancy and postpartum. And just due to lack of providers in our area, they just weren't able to get that care. And I said, well, then let's create something. So I collaborated with one of my mobile partners. We created a Mommy and Me event, brought in my community partners. So we had a venue site and brought in health and human service agencies to provide information. And we had, it is now an annual event. So we'll be going into our 4th year in 2027, and it's grown, and our provider will see all ages and accepts all insurances. So it's not just a UPMC event or just a pregnant mom event. It's the kids, it's the moms, it's the dads, it's the grandparents, it's everybody. Because if the family's healthier, that's the goal. Everybody needs to be healthy. So that has grown and really taken off. And the health and human service agencies that participate, like Next Step in health, the Head Start, it helps bring awareness to them as to what pregnant moms may need and how we can access that care for them. So I love our annual Mommy and Me event. It's a lot of fun. We get pictures with the Easter Bunny and just do all kinds of fun stuff in addition to providing information and dental care.
Wonderful. Okay. Anything for you, Leslie?
I feel that's it's really hard to follow up behind that one. It's a great event. I think in terms of what I've seen more recurring in my facility, it's really just being able to work with the dentist. As I formally mentioned, we do see new patients. And I think it's a great purview to have with kind of just assessing not only the FMX that we're taking, the screening that we're completing, whether it's an initial debridement that we're doing, but being able to then, refer this patient to the dentist if they're needing some type of emergency medical assistance to address a condition, especially with our pediatric population. We then usually refer to the dentist. They'll work with our benefits coordinator in-house to facilitate care for that child, to a pedodontist outside. Also, another hurdle we've had is right at this time of year. Here in Philadelphia, our school district went back to school on Monday, the 24th. So starting last year, we began initiating for about a 4-5 week long session, designated appointment slots within our provider templates to be able to meet the needs of parents who don't have a dental home established for their children. Essentially, those parents that are waiting till the school starts to get those school forms for their vaccines, their dental care. So this way, we're not seeing such an overload with walk-ins and people coming in. We're able to have them actually schedule and have that warm handoff between medical with their vaccines and being able to come right over to dental to get their screening. If time allows for it, we'll complete the prophy. If we can do sealants the same day, great. And I think that's also one other nice feature about having that federally qualified health center model or community health center. It really is nice having everything in one area. Like, I feel that's something a lot of people from private sector or those that may only use, their insurance to receive healthcare, they're really blown away when they come in and they're like, everything's here. I don't have to go here, there, and take the train or the bus to connect. And so it is nice. I feel it is convenient, and we definitely want to make sure if they're in the building, we can get them for as many services as we can in one day, because we honestly don't know if we're going to see them for another few years when they need their next school form for the next age checkpoint. So we want to try to provide as many oral health services as we can while that patient's in the chair.
Yeah, that's wonderful. And this is a question in terms of, and I think it's a really interesting one, what percentage of your patients are one and done? So meaning, what the services that can be provided by a PHDHP are the services that they need. Maybe they don't have restorative needs. Any thoughts?
I can speak to that, Helen. The mobile providers that I work with, well, the one pediatric practice, Miracle Dental Associates, is owned by Dr. Brittany Knoll. So their dentists, there can be a dentist on site, there can be a dentist via teledent, and absolutely there's that referral process. So they're not one and done. They can return to the mobile setting for recare. If, let's say they live in Venango County, but they're traveling to Wexford for restorative care, they can come back to Venango County for recare if they so want. The other mobile provider that I really like working with is Golden Onsite Dental with Alice Valenta, and she has a dentist integrated into her practice. So when she does her clinical, she again does screenings and exams via teledent and referrals for restorative. But I'll use Venango again as an example. If they want to return to see her because she has a dentist integrated, they can come back and see her. So it's not one and done. They stay connected to her. They can stay connected through me. We work closely with Venango County's Health and Human Service Agency, providing services out of their community hubs. They stay connected to those agencies and the hubs, so they know the schedules. But they are more than welcome to return if they so need to. Like Venango County, with having no care, that we have a lot of return patients. In fact, some of them only want to see Alice because she's wonderful and they love her and she's kind and she's a compassionate provider. So they only want to see Alice. So it's a great model, and it works well.
Any follow up there, Leslie?
Yeah, I feel it's a very, very small population that would just be, having received their initial exam with the dentist and then seeing me in the chair for a cleaning and, see you in 6 months. Um, I feel it's just lack of access throughout the patient's lifetime. Um, Now that they're here, they know about these resources that exist within the community, which is great. It's great that other community residents are sharing, about these programs and where they can receive care. Um, but also it's lack of provider hours. There's really not enough of us to go around. Like that really is the truth. I feel not only at the dentist level, but as PhDHPs, um, and full time even, there's not enough of us to go around. Our school district here defers everything to the school nurse. We don't have school-based hygienists here in our county. Within the district, they put that responsibility on the nurses, which I feel are just so overly stretched thin and may not even be in a school building every day at the same place. So I just wish there was more PhDHPs out here, definitely, for sure.
Well, I think that's a perfect segue into the very first question we got, which was really, can you speak to the limited utilization of PHDHPs? Is it primarily a lack of opportunities to work in public health settings, or is there more interest in earning the credential to expand skills and opportunities than there are opportunities to use those skills in practice? What do we think is the actual reason we don't see more PHDHPs out there?
I can start off, Helen. So being a PhDHP as an independent practitioner is a heavy lift. If you have an independent practice, it's all you. Whether you're credentialed with the MCOs or not credentialed with the MCOs, I mean, everything from the building of your practice to, making those community collaborations and treatment, the appropriate treatment sites to now you're practicing and now you're doing billing, documentation. It's a heavy lift. We're used as hygienists. We are accustomed to being part of a team and having all of that support. And when I pack up my vehicle and go to a care facility, I'm unloading, I'm loading, I'm unloading, I'm cleaning, it's all me. There's nobody there to bounce things off of or share. And that can be difficult. You have your referral system, but the dentist isn't in the next room where you can say, hey, this is an issue, help. Or an assistant, when you're practicing independently, you still have those things happen out in the wherever you're at that happens in the clinic. I've had patients, vomit. It happens, and you're just there on your own. Credentialing, getting credentialed is not an easy task. That becoming that practicing PhDHP is difficult. So I think that sometimes maybe turns people away. That do I need this heavy lift whenever I can go into private practice and work my 8-hour day, come out with a great wage, maybe some benefits, a decent paycheck, and live my life. I think being a PhDHP, part of your soul has to want to touch lives in a certain way. I've always worked private practice and also my own practice. And I would say, my private practice pays the bills. My PhDHP practice fills my soul. You have to have a calling, I think, to be that person. What was the other part of that question? What was the other part of that question, Helen? I'm getting lost.
Or is it, the interest in earning the credential to expand skills?
Yeah, that's
versus
difficult.
The opportunity. Yeah.
The opportunities, I think, are endless. It's what you make it. It's where you want to be. You could be where Leslie's at in an FQHC. You could be practicing like Golden Onsite does and have your big blue dental van traveling all over, providing care to underserved areas. I worked in a hospital based clinic when I worked for Titusville Area Hospital, and we had a clinic in the community. Working for a hospital is a great opportunity as well. the opportunities for a PHDHP are endless. It's what you make it, and honestly where your heart is, and where you want to practice.
Trying to which way to answer this first. I guess I'll start with the earning the credentials. So that took about, what is it? It's about like 3 to 4 years of full-time work to
About
get
3
those
years,
hours, I
3
think.
years
Yeah.
full-time.
Which, I mean, starting out of school, I struggled. I was between 2 to 3 offices. I was also temping. So it did take me a little bit of time to find a provider that would be able to speak and attest in that paperwork to obtain it. And then once I did complete that paperwork and was, issued the license, I definitely tried to spread the word to as many hygienists, like, you've been out of school as long as me, you should get it. It's just something to have in your back pocket if you need it. And I think just, again, falling back to ethics and practicing ethically, making sure I had that certification when working in the prison system, that was something very important to me. My employer at the time didn't push for that. And I'm like, my license is on the line. I want to make sure I'm practicing the way I'm supposed to, God forbid there was ever an audit. I just want to make sure I'm doing things ethically as it's put out there in the regulation. In terms of opportunity, I mean, as recent as within the last few months this year, I do check the job boards. I do check, LinkedIn, Indeed, word of mouth, and I feel like I'm rarely seeing anything, at least in Philadelphia, to have like a full-time PHDHP title. Maybe within some of the hospital settings, like in Coatesville, I think the VA hospital, that was like maybe the next direct opportunity, clinically speaking. I feel having the administrative and my master's in public health has given me the option to, if ever need be, to jump into another form of non-patient facing health services in terms of other options with, federal agencies. And again, with what's accessible here in Philadelphia for me. But I'm not seeing a lot of opportunity here in Philadelphia. I know for me, internally within our employer, the expense of employing one FTE, like a full-time equivalent public health hygienist at 37 and a half hours, you're factoring in their benefits, their paid time off. There's a lot of time off that's, pre-planned into our workforce calendar. So I feel that it's a large task to incur, funds to encumber and to take on in terms of a provider. And I think from my employer's perspective, they would rather invest in the dentist or the EFTA DA level. I feel like their perspective of a PHDHP is too expensive.
Okay, that's interesting. And there was a question about utilizing EFTAs and PHDHPs are not able to supervise, any clinical
Correct.
staff. So, you may, if you're working as an RDH, you may be working with an EFTA alongside, with a dentist under general or direct supervision. But a PHDHP out in the field is not going to be able to utilize an EFTA. In fact,
Correct.
as you guys have mentioned, you have to clean your own rooms. I mean, you can't even have an assistant to do your sterilization and clean your rooms.
Correct.
So that's something that we hear quite a bit as a big challenge.
Mm-hmm.
So something to think about. And, there is one more question here just asking about, for the independent practice owners doing mobile dentistry, have any been able to set up independent practices in medical facilities or partner with medical or other agencies, but maintain an independent practice? And I will address that a bit to say, you just have to be extremely careful that you're following the practice settings that are delineated in the law. So to practice in a medical setting, the area has to be a dental health professional shortage area. Whereas if you're in a Head Start program, it doesn't. So there are very careful rules that we have to follow, and that have to be followed to make sure that you're not stepping, into any gray areas. And I think, Leslie, with you at FQHC, and Crystal, the work you're doing with UPMC, you guys are pretty fully safe in that space, which is great. But I do think if you're considering independent practice, you really want to make sure. We usually tell folks to consult with an attorney to make sure you're fully interpreting the law the way that it should be interpreted, because it's tricky. Very, very tricky. So I guess, and I know we're coming up short on time, but if there's anything, just in a minute or so, anything that you want to say that you didn't get a chance to say, just in regards to the role that PHDHPs have in Pennsylvania, or any hopes you have for the future of them.
I would really love to see the advanced dental therapy role make its way to Pennsylvania. I absolutely see value in it. I learned about it in graduate school in Minnesota, what they're doing. Yes, giving local anesthesia was great. However, I had to go back to school to learn that. My curriculum didn't incorporate that during my training. But I really feel now, being on this side of the lens, having that dental therapy position would really service a lot of the state. I think it would be great even as a middle ground for the internationally trained dentists that we're seeing. A lot of other states have such adversities with fitting them in, and their regulations, or lack of regulation, Virginia, that they're going through. I think this could be a great opportunity to just get providers out to the public to continue serving and treating disease and, prevention.
Absolutely. Any thoughts, Crystal?
I would love for everyone that was eligible to get their PHDHP. And if you live in an area in, rural Pennsylvania where your school district does not have a certified school dental hygienist, to look into partnering with the dentist of record in working on Act 55 and providing those dental screenings, dental education, dental referrals to students. I work through Act 55 in my local school district, and I was able to bring mobile dental services into the school with that position, and we were able to reduce the decay rate by 35% in just 2 years. So we just do not see these kids going without care now. So, I'm able to do the screening and just be able to segue them right into a mobile dental event coming into the school, and it is a great partnership, and it is so good for these kiddos. The school I am with, they have a very robust program. They screen K through 7, all of them, and they all receive dental education, and I provide them all dental. They all receive dental hygiene kits, and so many of those kids, they come up and I get hugs, and they're like, "Thank you, I don't have a toothbrush." And you educate them, you empower them, and then you give them the tools to take care of themselves. Prevention is priceless, and if they don't know and they don't have that toothbrush to do that for themselves, what are they going to do? So it's a great program. It's providing healthier oral conditions for the future, educating these kids, meeting them where they're at, giving them the support they need. You're going to see the benefits of that years down the road. So I would encourage everybody to go to the PCOH website, look at their beautiful infographic that was created. It's very clear on how to follow that pathway, and reach out to those dentists of record with the school and become part of that school program. It's very rewarding. So thank you.
Thank you. Thank you both for all of your information and insight, and especially for just the passion you have for the work you do. It has to come from the heart, and it's amazing to see that. So we very much, I can't say enough about everybody who's out there doing the work every day. So thank you guys so much. As we wrap up today, we always do just share information. If you're interested in being part of our Speakers Bureau, we do try to get dental providers to go out and talk to kids about dental careers. So we'll share that information out after today. We would love to see more folks involved there. And another activity we have, just as a final slide here, we've been running our dental assistant radiology training. This will be our 6th session this fall, which starts in a little under a month. So if you know any dental assistants who need live support from a certified instructor to learn more and pass the radiology exam, we've got information about that. So happy to share that. And I think with that, thank you guys again, everybody, for attending, joining us to learn more about the public health dental hygiene practitioner. If anyone has any suggestions or topic ideas for future sessions, definitely let us know. We intend to keep these going. They've been well attended and popular. And if you want to review any of our previous webinars and previous subjects, they are available on our YouTube channel. So we'll have the slides and recording shared out early next week. And with that, I hope you all have a lovely weekend. Enjoy the last few weeks of summer. I know kids are all back to school or getting back to school, so enjoy that Saturday and Sunday while you can. So